So briefly, just the Meadows Mental Health Policy Institute. We're about 5 years old, but we're a nonpartisan database policy institute that's focused on mental health systems change. And we really do that work through two areas. One is local systems work, that's working in local communities such as the Panhandle here, and listening to you folks get together and identify issues here, and then taking what we learned from those different communities and using that to help shape state policy at the Capitol. So we're funded almost exclusively by philanthropy, and we're really there to be a resource to members of the Capitol. We have close to 45 people on our team now, most of which are master's or PhD level mental health professionals that work in mental health systems all across the country. So when a legislature or staff member calls us and asks, is this a good idea or a bad idea, we can tell them what it is, based on work in Michigan that one of our members did years ago or something of that like. So the first thing is building on our accomplishments. The Texas legislature has worked really hard the last 3 legislative sessions to put additional dollars into behavioral health. Just this last legislative session alone, they put $750 million additional dollars in behavioral health. A large part of that was due to Speaker Strauss and the Select Committee on Mental Health that your very own Ford Price from right here in Amarillo was the chairman of. But that was an impetus for a big increase in funding, as well as at least a dozen significant pieces of mental health legislation that were passed last session. Many of those Chairman Price was either the author or the sponsor of, and I'll visit on those in just a minute. With a $750 million increase last legislative session alone, over the last 3 legislative sessions, there's been close to a $1.7 billion increase. So pretty much ever since Sandy Hook in December of 2012, there's been a bipartisan focus on mental health, and there's been additional investments each legislative session. So we still have 1,000+ people a day moving to Texas. So what we mean by building on our accomplishments is that we've done great work over the last 3 legislative sessions, but we can't take a step back. We have to take the next step forward, because this is a long process that we're doing in our to advance our behavioral health system. One last note here, kind of our measuring stick, is that there was $7.6 billion appropriated to behavioral health last legislative session. That was around 20 different state agencies received some sort of behavioral health funding. So anything above $7.6 billion in this budget cycle will be an increase in behavioral health funds. I want to provide an overview or a couple grant programs. I'm sure you're familiar with them and have discussed them right here at the Panhandle Behavioral Health Alliance, but these were both programs that were put in place last session. The legislature, they've done a lot of things. They put in dollars in crisis. They put dollars in our wait list to make sure that people like Bud don't have a wait list for adults or children's mental health services, and also get some bump for increased caseloads and sometimes cost growth. But beyond that, if they've invested in targeted funding, the legislature has really looked at grant programs, and all those grant programs have the same theme. They have a targeted population. It started off with looking at the intersection of homelessness and mental illness. That was followed up by a bill that targeted veterans and mental illness. And in this last legislative session, there was these 2 bills I'm going to talk about. So that's one theme, a targeted population with the grant bills. And the second thing is some sort of local match component to it. So the way the state does local match for most of those programs is communities that are counties less than 250,000, they have a 50% match requirement. So if you want to draw down $1 million in grant funding, you have to have a $500,000 local commitment. That can be in kind, it can be anything but state or federal dollars. So it can be local county dollars, and again, I think you use some in-kind contributions to make that match here, but the legislature is very flexible on how they do that. So the last legislative session, the Senate passed Senate Bill 292, and Chairman Price was a sponsor of this over in the House side. This bill was specifically targeting the intersection of criminal justice and mental illness. So Senator Huffman out of Houston, she had a Harris County jail diversion pilot project, and that bill was set to expire. But basically it was $5 million a year from Harris County, matched with $5 million a year at the state level. And it was to implement strategies in Harris County to keep people with mental illness out of their jails. So true jail diversion, to put them somewhere else except in the back of a squad car headed to jail for mental health treatment. And so what the legislature decided to do was take that program, since it was expiring, and expand that statewide so any community in Texas could draw down dollars for that same purpose. What I want you to note here is that the funding for that last time, it was $12.5 million in the first fiscal year. That was less funding in the first fiscal year because it was intended as ramp-up dollars, and the full funding was $25 million in the second fiscal year. So that's what was funded in the last budget cycle. Harris County, on top of that, they continued at $5 million a fiscal year moving forward. The next grant program was Chairman Forprice's grant program. This came out of the Select Committee on Mental Health. And basically this program, I know that you've received funding, so I'll be brief. But basically Chairman Price, instead of saying I want to do a grant program that targets a specific population, his grant program is designed to fill any gaps in adults or children's mental health services. So basically local community, come to us, tell us what your gaps are, and this is your way to draw down local dollars. Just like the funding was ramp up in the previous bill, this one received $10 million in the first fiscal year, ramp up dollars again, and then $20 million was intended as the full funding level in the second fiscal year of last budget cycle. The other difference for this one that the applicants can be any nonprofit entity, which I know you received your funding through United Way partnership here that's a nonprofit, or it can be any governmental entity. So a school district, a city, a county, a institution of higher education like Texas Tech, any nonprofit or governmental entity is eligible for House Bill $13. I'm going to show you just a map real quick where dollars have gone out. The way they split up Senate Bill 292 is they broke some of the funding and did an urban round. The way the state defines urban for these grant programs is if your county has 250,000 or more. There just so happens to be 20 of those counties in the state. So 20 counties were eligible to apply for those dollars. Lubbock did receive dollars through Senate Bill 292. Of course, since your counties up here are less than 250,000, you were in the rural round for Senate Bill 292. And Bud in Texas Panhandle had a successful applicant to draw down Senate Bill 292 jail diversion dollars for Potter and Randall County up here. House Bill 13, you'll see that House Bill 13 has a lot more coverage than Senate Bill 292 does. And again, that's going back to House Bill 13, any nonprofit or governmental entity are eligible to draw down those dollars. And you did receive multiple requests for funding here. Give me 1 second, I just want to see the exact ones for House Bill 13. So the way they did House Bill 13 is they did 2 rounds. They broke it into the first round was for any local mental health authorities, and then the second round was for nonprofits and any other governmental entities. And so in the round for the local mental health authorities, Bud and Texas Panhandle again received House Bill 13 funding under that for Potter and Randall counties. And then the second round, which was known as a request for applications for the nonprofits and other governmental entities, Family Support Services of Amarillo received funding. The Texas Tech Health Science Center received funding to expand their Twitter program into some school districts up in this area. United Way of Amarillo County, of course, that's your group, the fiscal agent for your group. And then West Texas A&M University received funding for Randall County. So you had not only Bud, you had 4 different entities that were on the nonprofit or governmental entity side that received funding. So the Panhandle did really well as far as the size of the population and the amount of successful awardees that you had, because both of these programs, you saw the dollars in those original slides, but they were severely overprescribed. There was more demand than there were dollars were available, and so the most competitive applications rose to the top, and it just so happens that you had multiple competitive applications that received funding. I mentioned the Veterans Program being a model for this grant program earlier. This was the program that I was referring to. It was Senate Bill 55, created 2 legislative sessions ago. It created the Texas Veterans and Family Alliance Grant Program. And again, targeted populations. The goal of this one was grant dollars to provide mental health services and treatment to veterans and their families. This one has always been funded at $20 million over the biennium, so over the 2-year budget cycle ever since it was launched. And the applicants for this program can be any community collaborative as long as their goal is to treat veterans and their families. The key thing I want to mention on this is that $20 million, they sent that out, the Health and Human Services Commission did. They've awarded about half those dollars for this budget cycle, and you had 3 successful applicants from up in this area, Family Endeavors, Family Support Services of Amarillo, and Star Care based out of Lubbock actually extended up in this area with some of their veterans programs. But there should be another round of this coming out in the next couple of months. There's still about $10 million for this budget cycle that's not spoken for yet. So there'll be another request for applications to release and draw down additional dollars. So another funding opportunity that this area might be able to take advantage of. So when we talk about these grant programs and we talk about building on our accomplishments, I talked about the step-up dollars. So it was 12.5 and 25 for SB 292 last time. So for this session, we need at least 25 million a fiscal year plus 5 million for Harris County. So that's 60 million this biennium. The good news, since Laura saw me in Lubbock in December, is that the House and Senate both introduced their base budgets, and there's $60 million in both budgets for Senate Bill 292. For House Bill 13, remember it ramped up from 10 to 20, so we would at least $20 million a year or $40 million over the biennium. That is again fully funded at $40 million in both the House and Senate budget. And the Veterans Bill I just mentioned is funded again at $20 million in the House and Senate budget. So the Senate Bill 292 and House Bill 13, I expect that they'll stay at those levels, and because the House and Senate agree on those now, and that'll be in the final budget sometime in late May. But you need to be thinking about positioning yourself for additional rounds of this to occur potentially in this fall. The HHSC, the Health and Human Services Commission, will more than likely send out new requests for applications for Senate Bill 292 and House Bill 13 funding. So be thinking about how you position yourself for it, if you want to continue what you already had, or if there's some tweaks you want to make to your application from last time. Maybe there's some additional counties you want to pull in, just something to be thinking about. I'm going to talk about state hospitals now. State hospitals is a big ticket item last legislative session, as well as this legislative session. This list here, there was a report done about 4 years ago called the Canon Design Report. And what Canon Design did is they went out and looked at our 10 state hospitals. There's 11 on here, but we have 10 state hospitals, but one of them, the North Texas State Hospital, has 2 campuses. So they're technically 10 state hospitals. But what that Canon Design Report did is it determined that the ones on the left were too far gone, that they needed to be bulldozed. The ones on the right just needed significant renovations. So you can see our oldest state hospital is Austin State Hospital, built in 1861. That was the start of Civil War, and Abraham Lincoln was our president at that time. You'll see by and large beyond that, beyond Austin and San Antonio, most of our state hospitals, it'll be more apparent in the next slide here. This is our catchment area for our different state hospitals, but you'll see beyond Austin and San Antonio, most of our state hospitals are located, for lack of a better term, in very rural areas, or what some people call BFE. And that's not a database term, but that was built on a system design in the 1800s where people that had mental illness went to live their lives at a state hospital and were housed there for long periods of time. So what we've been pushing at the legislature for over 3 years now is we need to redesign our state hospital systems closer to where people live, where they have supports and family in their communities. As you can see, these catchment areas are very spread out. So San Antonio, for example, people in Laredo or Brownsville, if you're law enforcement there and you need to get a state hospital bed, they have to take the journey up to San Antonio. Harris County, they are zoned for Rusk. So if somebody in Houston needs a state hospital bed, it's a 3-hour trip to Rusk. But again, this is mostly an 1800s design. One thing I will mention about Harris County, they have their own hospital down there. It's not listed on the state hospital system because it's a joint project between the state and Harris County. It's jointly owned, but it's operated by UT Health, which is the medical school down there. It was opened in the 1980s, and so Harris County does have that resource, and that's kind of the model we believe for redesigning our state hospital system moving forward. Because UT Health does very well with their outcomes there, and they have better access for workforce issues. And another issue we all know the state is, by and large, has an issue with mental health workforce challenges. So not just psychiatrists, but all the way down to forensic nurses or social workers. The other problem with having the state hospitals out in these rural communities is that they have a very difficult time retaining their workforce there. So that UT Health model in Houston, they're able to use professors and other people that are in that school to provide treatment there. So the legislature has really been looking at that medical school state hospital partnership for the last few years. So the legislature recognized that there was a need to redesign and transform the state hospital system last session, and they invested $300 million out of the rainy day fund to do that. It was intended as the first phase of 3 phases, so a 3 biennium approach, and that was just the first $300 million. And so these are the lists of projects that were funded out of that first $300 million. This totals right at $293.7 million that's been spent so far. But a couple of key things to note on here. One is our max security beds. I'm going to flip back to this other slide real quick here. Y'all are lucky up here because most of the state doesn't have this access, but there are certain crimes that people are charged with and they're determined incompetent to stand trial and they need a state hospital bed. They're labeled max security unit offenses. They can only go to a max security unit facility. The North Texas State Hospital at Vernon is the max security unit for the entire state. There is some beds at Rush State Hospital. It's only around 60 beds, but the bulk of the beds are all at Vernon. So anybody that is charged with a maximum security unit offense, either in West Texas or down in the Valley, if they have somebody like that in their jail waiting for a state hospital bed, they have to go all the way up to Vernon for that. We also have a wait list of over 600 people in our jails right now that are waiting for a bed in a state hospital. Over 400 of those are on our max security wait list. So the legislature recognized that max security was a big issue, and they invested out of this initial commitment. They're putting 70 new max security beds online at Kerrville, west of San Antonio, and 60 additional beds for max security capacity at Rush State Hospital. So those will be 130 new beds coming online that will be available for anybody in the state to utilize. Beyond that, Austin State Hospital and San Antonio State Hospital, those were two of the state hospitals from the 1800s. They partnered with their medical schools and have been using these dollars for planning dollars and planning a new state hospital in conjunction with their medical schools for over the last year. I'll talk about that more in just a minute. And the last thing, the Harris County Psychiatric Center that I mentioned that has that joint partnership, they received $125 million and they're building a new 240-bed facility right next to the current facility, which is located in the Med Center in Houston. The cool thing about that is it doesn't really affect y'all up here, but San Antonio, this is their catchment area down here. You have them redesigning and planning for a new state hospital. Austin, you have them doing the same. Houston, now building a new one. That's going to allow the state to redesign these catchment areas and think better about where state hospitals should be located in relation to the people that are being served. Because right now, people from Galveston are going to Austin. That doesn't make any sense if you have a brand new 240-bed facility in downtown Houston. So the legislature, this session, what are the opportunities around that? We expect that the legislature is going to put at least $300 million additional dollars in the state hospital system multi-session redesign. The reason we believe that is because the Senate supplemental budget contains $300 million from the rainy day fund. The House hasn't filed theirs just yet, but I expect it to be some funding in there as well. And then as far as potential opportunities, what is that funding going to go to? The Austin State Hospital, as I mentioned, they've been doing their planning. They finished their planning at the end of December. They brought a proposal for a $283 million new hospital up to the state. The San Antonio State Hospital did the same, except their cost is $323 million. Beyond that, you'll notice that out of the big cities, Austin and San Antonio are working to get fancy, shiny buildings. Houston has one under construction. Little old Dallas hasn't had anything yet. So there's been discussion of Dallas potentially getting in the mix for planning dollars, as well as right here in the Texas Panhandle potentially getting planning dollars. Something that you have that is a good model, we believe, for up in this area. We haven't completely looked at it. That's the process of planning. But down in Lubbock, they have Sunrise Canyon, which is a facility run by the local mental health authority there. What you don't need up here is a 300-bed facility in Lubbock. You need smaller facilities that are closer to your community. So a Sunrise Canyon type model up in Amarillo, we haven't run and done an analysis of the Panhandle, but that might be something that works well for this community. You can also look at contracted beds, which are dollars the state gives in order to contract at the local level for private beds. But it should be clear that talking about a state hospital in the Panhandle is not a $323 million San Antonio State Hospital type build up here. So potential planning dollars for that. I know that Ken King from up here in the Panhandle and Chairman Price have had some discussions about that, as well as Senator Perry from down in the Lubbock area, because he hears a lot from those county judges as well. And then finally, Senator Nichols, that represents the Rush State Hospital area, he would like to see some more non-max security beds over in that area. As a nonpartisan database policy institute, we would say that is a bad idea, because that's just perpetuating the model that's out in Rusk. But we understand Senator Nichols' position on that, because Rusk, of course, is a big workforce driver in that community. But we think ideally communities like that are more zoned for max security, which requires fences and certain security measures like barbed wire. But the big item that we see this session is children's mental health. Over the last 3 legislative sessions, the legislature is really focused on the adults' mental health system. There has been gains in the children's mental health system, but it's been a long time coming just to get members of the legislature to realize that 50% of mental illness begins by age 14. And the people that we're dealing with that are in crisis, or we use the cancer analogy, in stage 4 in our mental health system right now, those are people that didn't get the right treatment and intervention in childhood, and they didn't just happen to be like that overnight. That was a long period of deterioration. So the only way we're going to get ahead of the curve is to intervene earlier and focus on our children's mental health. And so the legislature is really recognized that this time, and really the impetus for that was first Hurricane Harvey. There was 200 plus school districts affected in the Hurricane Harvey region. We staffed the TEA, the Texas Education Agency. They created with Governor Abbott a task force on school mental health supports, because at first people were worrying about my house got destroyed or my school got destroyed. And it was a short time after that that kids, because of the trauma they experienced, they started seeing the result of that in the form of anxiety or depression acting out in schools. And so we worked with them, and the legislature realized that that was going to be a big need as part of the Harvey rebuild. Then in May of this year, of course, the Santa Fe school shooting tragedy, Governor Abbott pulled in a bunch of series of roundtables, and what we've been very clear on with that message is that we don't want to further stigmatize mental illness. We don't want to say that school shooters are people that are mentally ill, because by and large that's not true. These are people that are evil or have personality disorders. And we don't want to make the claim that if you go out and provide the most robust children's mental health services in the world, that you're going to find the next needle in the haystack school shooter, because these are tragic but infrequent events, and it's just, we don't have the technology to be able to detect that type of thing. But what we've had said, if you want to find the needle in the haystack, you have to treat the hay. These are things that are good for the children's mental health system that we should be doing already, and the legislature has latched on to that along with a few other things. So what is the legislature going to do on that? This slide here, I'm going to hit on 2 things real quick. This is mainly to show you that we like numbers and that we crunch data, but this is the total population for children and youth in Texas. It's right under 5 million, but I just want to focus on 2 key things. One is this at risk of out of home and out of school placement. That's roughly 20,000 kids in the entire state. Those are the kids by our prevalence estimates and data are at the most highest level, that have the highest level of need. And then down at first episode psychosis, I'm going to talk about that in a minute, 900 new cases of first episode psychosis a year between age 12 and 17. What we don't want to do at the Capitol is come to the Capitol and say that there's almost 2 million children in the state of Texas that have some sort of behavioral health need, because that seems like a problem that the legislature can't solve. That's too big to treat 2 million people. So we like to put it in bite-sized amounts that we think you can make significant gains and significantly change people's lives, and that the legislature can grasp. I mentioned this earlier, I'll just skip this slide here, that the half of all mental health conditions occur by age 14, but by young adulthood, 75% of lifetime cases have presented. And the key thing here is early detection and intervention plus appropriate treatment. So last legislative session and the session before that, there was a lot of talk about mental health first aid. I know that you're doing trainings through this. There's also a big push to do trauma-informed care training, especially for educators. Those are great things. I was actually in Senator Schwartner's office and helped draft the original mental health first aid bill in the 83rd legislative session. But that's kind of where we were at that point, was we need just to talk more about mental health with kids. That's great, making people more recognize that, but you have to have somewhere to send those kids for treatment afterwards. So it has to be 1 and 2. Appropriate treatment has to be part of the puzzle. As far as the ideal children's mental health system, we break it down into three key components, and this is a result of the work we did in Harris County. We were funded by the Houston Endowment there to take a look at the children's mental health system and make recommendations for designing the ideal children's mental health system. So part of our recommendations was these 3 components. One is helping local schools identify needs and link kids to help. I'll go into more detail on this in a minute, but we call this a school liaison role. Second is helping our pediatric primers find and treat mental illness when it's mild to moderate. And then finally is making intensive treatment available for children with the most severe needs, and that's that 20,000 number I referred to a couple slides ago. So this first one, helping schools get expert evaluation. The school liaison role that we call here. Since the Santa Fe tragedy, There's been a lot of discussion from different associations coming up to the Capitol, and some have said, well, we need a counselor in every school, or we need a school psychologist in every school, or we need a school-based clinic. Our position on that has been, you need somebody that is able to coordinate identification and linkage. There's not a one-size-fits-all solution for the state of Texas. Not every school is going to be able to afford to have a counselor there. It might be telemedicine or telehealth because they're in a rural area. In more populated communities like Austin, they have school-based clinics that are run there. So Austin ISD, on numerous of their campuses, they actually have clinics on their campus. That's not going to be possible for every school district. So what we've said is that you need a pot of dollars that school districts can drive what works for them, what they want to fit into this solution. We also can expect, even if a school has a school counselor, that they're going to be able to treat everybody's needs. Sure, they're going to be able to talk to that kid and maybe get them through some things, talk to their parents, but there's going to be some kids that have more intensive level needs and treatment from that, and that counselor is going to have to refer them to care somewhere. So that's the referral and linkage component to that. So this next slide talks about the different funding opportunities for this. The Texas Education Agency, because of the work from the School Mental Health Roundtable, they proposed the Safe and Healthy Schools Initiative. This comes out of Governor Abbott's recommendations, and it's their #1 exceptional item. What that means at the Capitol is all the state agencies come and they have a base budget request where they're asking for a certain amount of dollars. They then have a wish list, which is known as their exceptional items, and it's listed in priority. So their #1, their top exceptional item is, legislature, please fund this for me. So their top exceptional item is the Safe and Healthy Schools Initiative, and they requested $52.5 million to be split up among 4 key components. That was mental health supports, positive school culture, facility safety, which is going to be things like school hardening, and then emergency response coordination. What the legislature has done thus far, the House-based budget that came out, they put $54 million in the Safe and Healthy Schools Initiative. The Senate has not funded that yet, but discussions are ongoing, and I'm optimistic that it will be funded at the end of the day. But out of that $54 million, $37 million of that went to the mental health supports and positive school culture components of it. The bulk of those are grant dollars that, the way it's envisioned now, is local ISDs will be able to pull those down to be able to, again, fill that school liaison type function and use it for whatever they want in their school. There's also additional dollars in there for mental health first aid, trauma-informed training, and this positive school culture component is things like PBIS and social emotional learning. So things that we really need in the environment to not have a zero tolerance school that's just going to overreact and send all kids that are acting different automatically to alternative school or into our juvenile justice program. So that is a good thing to keep an eye on. House Bill 13 is the other avenue. I mentioned it's funded at $40 million in the base budget, but because governmental entities are eligible to apply for that, school districts can apply for that. So there might be some room for school districts to apply for HB 13 dollars through that, or there might be a way to position for additional dollars to get invested in HB 13 specifically for the school response. I'll say that Chairman Ford Price has already filed a couple key pieces of legislation as well related to children's mental health. Out of all the bills that came out of the Select Committee last session, the one bill that Chairman Price did not get to the finish line was House Bill 11, and that was a children's mental health bill last time. It really dealt with schools and put it involving mental health more in curriculum. It also had some, it tied mental health first aid into an optional continuing education requirement for educators. So there's things like that in there, and it's a really good bill overall. It's been refiled as House Bill 1069 this time. It's a lot more developed than House Bill 11 was. He was able to get some of those things passed in another bill that passed as an amendment last time, but this House Bill 1069 that Chairman Ford Price filed, I would suggest that you take a look at that and keep an eye on it. And as you know, Chairman Price got appointed to the chair of calendars in the House. Calendars probably seems kind of boring to people outside the legislature, but it's one of the most powerful committees in the House because they control the flow of legislation that comes to the floor. They get to say which bill's coming and at which point it's coming. So everybody likes to be friends with the calendars chairman. Everybody likes to be friends with Ford Price anyways because he's a great guy, but now they really like to be friends with Ford Price. And so the other thing they do is when your bill is up and your calendar's chairing another committee, they're very eager to hear your bill and support you in making sure your bill gets passed. So I think House Bill 1069, formerly known as House Bill 11 from last session, will get across the finish line this time. He's also filed House Bill 1335 that would fund school-based behavioral health clinics, and he's got some other bills related to children's mental health. So, and he's not the only one. There's a lot of other members on there. It's just because Chairman Price is, of course, from your area that I want you to know about, and two, because he's widely respected on these issues because he spent a year as the chairman of the Select Committee on Mental Health, and then he was chairman of the House Committee on Public Health last session, and then he spent the last year as chairman of the Opioids and Substance Use Committee. So he's one of a handful of go-to experts in these areas, and people in the Capitol are give him a lot of deference on these bills. The next bill I want you to know about is Senate Bill 10. This bill was formerly known as Senate Bill 63, but Senator Nelson refiled it as Senate Bill 10 yesterday. It creates the Texas Mental Health Care Consortium. And what this is a consortium of all 12 state-funded medical schools. They've been meeting for about 3 years now. The chairs of department psychiatrists from all our medical schools working together on how they can serve issues of importance to the state. And so Senator Nelson's Senate Bill 10 formalizes those schools, and it puts funding in there for two things. The first thing is it has funding for telemedicine and telehealth programs. Things like the Twitter program that's down as Texas Tech. Texas Tech Health Science Center could take advantage of Senate Bill 10 and use those to expand the Twitter program in this Panhandle area. The other key thing about Senate Bill 10 is that the Senate funded this at $100 million in the base budget in the Senate, and Governor Abbott named this as an emergency item yesterday, which means that this bill can be taken up and debated and passed right away. So this is a critical bill to keep your eye on this session. Leveraging pediatric primary care providers, we just went through the mental health school liaison role. The primary care provider, 75% of kids that have mental health conditions present in a pediatric or primary care setting. So it's critical that we enable pediatricians and primary care docs to treat those conditions in-house. The method to do this is what's known as a Child Psychiatry Access Program. Nearly 30 states have implemented these programs. They're known as CPAP programs. Massachusetts is the longest running program. But basically what it is a hub at the medical schools across the state where they have people like a child and adolescent psychiatrist, social workers, care coordinators that are on call there, that any pediatrician or primary care doc in the region can call them to walk through essentially as a consult for a mild or moderate mental health condition in their setting. What we don't want primary care docs to do is say, well, I can't handle that, I need to refer you to a child or adolescent psychiatrist, because we don't have enough of those to go around. We have wait lists just as it is. So we need to enable them to treat those settings or those more minor and moderate conditions in their primary care office. The other key thing, I mentioned that 75% of kids present there because, like, I have a 5-year-old daughter. If she has something wrong, physical or mental health, I'm going to go to the pediatrician. And just like a pediatric office, if you go and you have a sprain, the pediatrician doesn't say, well, I'm going to send you to the orthopedic surgeon. By and large, they're able to treat that sprain right there. If it's more critical condition, a severe need, they might send you to orthopedic surgeon, but we do this already for physical health. So 31 states have already done this. Massachusetts is the oldest running program. They've been going since 2004, and they now treat 2/3 of their mild and moderate conditions in children in primary care settings. So that's the data they've been able to do after starting up that program for 15 years. So the second thing that Senator Nelson's Senate Bill 10 does is it establishes a statewide network of these child psychiatry access hubs at our medicals across the state. And Texas Tech is well positioned to be one of those and to provide that resource for the entire Panhandle. The funding on it, it's part of the $100 million. It's not very important, but it basically, there's enough funding in there in the part that's segregated to the CPAP model to fund 10 of these across the state to provide enough coverage for our 4.9 million children between the ages of 6 and 17. And the model for this was based after something in Texas that they ramped up in response to Hurricane Harvey down in Houston. And the last thing on the children's mental health, the highest level of needs. The key thing is those kids don't all have the same type of needs, and they don't all need the same type of treatment. We've done assessments in close to 20 different communities across the state, and our estimates from those assessments is that for kids that have the highest level of need, we have the capacity to serve roughly 5% of those at that highest level of need. We don't have very much between routine outpatient visits and intensive inpatient or residential treatment centers. We don't have really the intensive treatment that can be done in the home, working with children and family, things of those natures, evidence-based practices that they have in other states. But one area where the state has done a good job and does have good traction for the last few legislative sessions is around first episode psychosis. I mentioned the 900 new cases for youth and adolescents each year. That's a manageable number that we think that we can go after. In psychosis, for those of you that aren't mental health clinicians, that's two things. It's more than two things, but basically it's people that either see things that aren't there, or they hear voices that aren't there, or they have delusions that something is true when it's really not, like they're Superman. And so generally, when people have those hallucinations and delusions, it's called a first episode psychosis, and the best treatment is to intervene aggressively within 12 to 18 months. There was actually a big project in New York a couple years ago known as the RAISE study, and that was what they came out with at the end of the day, that the solution is actually to treat people with psychosis early and often. So that's the type of things that research tells us these days. The key thing on this, on untreated psychosis, where I said that mentally ill people are by and large more likely to be victims of violence. For psychosis, that's the only part that's actually different. People with untreated psychosis are 15 times more likely to commit homicide than people with treated psychosis. That doesn't mean homicide is I'm going to go shoot up a school. It's often things like familial homicide or even suicide. You can see below it, elevated suicide mortality, 24 times the risk of their peers for people with first episode psychosis. And it's not just people with psychosis. We have some of the highest youth suicide rates we've seen since the 1970s going on in the US these days. And on average, treatment is delayed 5 years post-onset, which is really key for psychosis because it can do long-term damage to your brain as you're having these repeated psychotic breaks. So what the state has done, they've been able to leverage federal dollars. In 2014, when we started, we only had 2 first episode psychosis teams in the entire state. We had 1 in Dallas and 1 in Houston. And then 2 years later, in 2016, we were able to get additional dollars from the federal government through the Mental Health Block Grant, and we were able to start up 10 additional teams in 8 different locations. One of those is Texas Panhandle, right here in Lubbock. Right here in Amarillo. I'm sure that goes over real bad. I appreciate nobody throwing a sandwich at me. So, sorry about that. I'm on planes, trains, and automobiles lately, so I'm not exactly sure where I'm at right now. But anyways, so we went from having 0 teams in 2014 to having 10 teams, or 12 total teams located at 10 community centers across the state. Each one has a caseload of roughly 30 people at a time, so that's a capacity right now the state has to serve roughly 360 people. So that's not going to cover all our new cases of psychosis, but it's definitely a start, and it's a lot better than where we were in 2014. And then as far as moving forward on that, last year in March, there was a giant appropriations bill that was rammed through Congress that it was a Christmas tree, that everybody got a little bit of everything, had a really big fiscal note on it. Well, the state was able to get $3.7 million through that to increase coordinated specialty care access, and they're currently finalizing contracts to extend that out to 22 different community centers. So we have 39 community centers in the state, and by this summer, we're going to have first episode psychosis coordinated specialty care teams at 22 out of those 39 centers. That's a huge change since 2014. Beyond that, the Health and Human Services Commission, I mentioned exceptional items earlier. They have an exceptional item asking for $7.9 million a year for each fiscal year coming up over the next 2 years to expand coordinated specialty care sites. That would be to be able to expand coordinated specialty care all 39 local mental health authorities, as well as to medical schools and other community providers. So that's full-blown capacity for the state. The key thing with that is that each coordinated specialty care team is about $400,000 per year, so it doesn't have to be a legislature, please fund us at 0 or $7.9 million. For every $400,000 the state is willing to invest on that, we could ramp up one additional team that can serve 30 additional people at a time. So we think there's some traction around that for next session. So research I'm going to talk about briefly because this is another component of Senate Bill 10. But that shares the psychiatry group I mentioned. One of the big things that they wanted to work on is coalesce around 5 different research priorities for the state. We use MD Anderson. The way MD Anderson is run by the University of Texas, they're a state institution, but the way that they became a beacon of hope across the world for cancer treatment was because of their research dollars and faculty that they were able to pull in there. We don't have anything like that for mental health. We did an inventory among all the medical schools about how much federal NIMH, or National Institute of Mental Health dollars we were drawing down. We're drawing down 3% of the federal share, and Texas is 9% of the population. So these chairs of psychiatry from all our medical schools, they coalesced around these 5 research priorities, and they're wanting to work together to leverage more research dollars and draw down more federal research dollars from the state. So instead of people at UT Southwestern and people at UT RGB in the Valley both doing depression research, working on those together to leverage their expertise at both systems. So Senate Bill 63, because it does formalize that consortium, I want you to be aware that it also has a mental health research component to it, and it's basically to leverage the experience of those chairs and draw down more federal NIMH research dollars. The last thing I'm going to end on here, and then we can open up for discussions and tell you possibly the big elephant in the room that I didn't mention in the presentation. There's a couple things going around the Texas Judicial Council Mental Health Committee. This is the policymaking body for the judiciary. It was launched 2 years ago by one of our fellow board members, Justice Harriet O'Neill. She was a former justice on the Supreme Court of Texas. But the judges have taken a big interest in criminal justice issues, and part of our wait list issues and our state hospital issues is the way that judges think about and process mental illness. We have roughly 2,500 beds in our state hospitals right now. 34% of those beds have been taken up by people that have been over 365 days. These are people that are never going to get better in that setting. They're never going to regain competency, but judges continue to send them back to the state hospitals. If we could just turn over a fraction of those beds, we could get through the entire wait list that we have in jails. So the Texas Judicial Council is out there thinking about that. We also don't want to just build new state hospitals and have 34% of the beds being caught up by the exact same population. We have to redesign the system and better think about how we're doing this. Better address Texas behavioral health workforce emergency. The biggest thing to follow on this is that one, the legislature, both the House and Senate budgets, increased the graduate medical education or residency dollars by over $60 million in both budgets. That gets us to a 1.1 to 1 ratio. For years, the legislature, our medical schools, we were graduating more docs than we had residency placements in the state. And so those doctors would go out of state to do residency. Once a doctor does their residency out of state, they get comfortable there, and by and large, they stay within roughly an 80-mile radius of where they do their residency. So the legislature, every session, has been very good at investing dollars to make sure we get to a 1.1 to 1 ratio. And what that means is we have 1.1 residency slots for every 1 medical school graduate in Texas. So we have enough for everyone in Texas, as well as to grab some from out of state that other taxpayers have paid to educate. That's one thing. The second thing is that there's an agency at the state known as the Sunset Advisory Commission. The Sunset Commission, they review state agencies roughly every 10 to 12 years and make recommendations on whether that agency should continue. And if they do continue, are there things that they can do to make them operate more efficiently and effectively? Last legislative session, all of the behavioral health professions were up for sunset review. So the psychologists, the social workers, the licensed marriage and family therapists, and counselors. The problem is that LPCs, LMFTs, and LCSWs are all buried in the Health and Human Services Commission right now. The Health and Human Services Commission is the biggest state agency in the entire country. It has 55,000 people, and by and large, they deliver services and oversee Medicaid. So processing licenses for new professionals, whether they graduate or they're coming from out of state, has gotten buried, and it's taking months and months on end to get new people licensed. We have a workforce shortage. We can't allow that to happen. So last session, they proposed to take those 3 professions out of Health and Human Services and put them with psychologists. The psychologists currently have their own board. The psychologists didn't like that because they wanted to keep their own board by themselves, and so the bill died. And there was a lot of other good things in that bill last time. Things like eliminating face-to-face board exams that also keep people from getting out into our workforce, or reviewing clinical hours, how many clinical hours are required before a person is eligible to be licensed, and comparing that to other states. Last time the entire bill went down in flames because of that. It's back this time. They basically continued the agencies for 2 years. Sunset has unanimously adopted those recommendations and all that policy again. So it's going to be back. Senator Nichols in the Senate is going to be carrying that. And I'm hoping with Chairman Price now being the calendar's chair, overseeing the flow, that's where it died last time, that he'll be more receptive to getting that out to the floor, because it would be a big issue for advancing our behavioral health workforce. And then lastly, expect to see traction around opioids and substance use disorders. I mentioned that Chairman Ford Price was appointed to the Select Committee on Opioids and Substance Use Disorders. Opioids has gotten the largest amount of focus thus far. That's because the president has declared it as a national emergency, and the state has had an influx of tens of millions of dollars to get out towards opioid treatment. But there's more than just opioids that are in substance use disorders. Alcohol and methamphetamine are two of the other big drivers. So there's been multiple bills filed, and I expect to see traction in the House and Senate around opioids and substance use disorders. So with that, that is the end of my presentation. I know there was a lot of information, and I know I didn't talk about everything in here. The bird in the room I didn't talk about was the 1115 waiver, so I'm happy to talk about that with you or any other things in the community or that you'd like to know about that are going down in Austin. So with that.
So you just mentioned the waiver. Is there an opportunity to amend and expand the existing 1115 waiver, or is that?
I think so, yeah. And so is everybody here familiar with the 1115 waiver? So it's a big issue. Of course, 1115 waiver, there's two funding pools. There's uncompensated care pool and there's a DSRIP pool. The DSRIP pool has been providing about $500 million a year to behavioral health projects. They negotiated an extension of the 1115 waiver last year. The state was able to do that with the federal government, but those DSRIP dollars are tapering down and they're completely going away in 2022. The UC dollars are also going down as well, but they don't completely go away like DSRIP. So there's a big group that's working on this. The Texas Council that represents all the local mental health authorities, the Texas Hospital Association, Texas Medical Association, Children's Hospital Association, they're all working on a proposal that's called Amend and Extend. And there is traction for that. I think they have all the key people in are sounding the right messages. You're not seeing a lot like you usually would, like the press would be panicking. You know, you see stories about the 1115 waivers coming down because we've had all these gains, $1.7 trillion in the last 3 biennium. But all that DSRIP money, that additional $500 million just for behavioral health, that's occurring outside of that. So you can imagine if that gets vacuumed out of our system, what that's going to do to our wait lists and ability to meet the services in the state. So I think there's a comfort level that something, this amend and extend plan is going to move forward and be worked out. Otherwise, you'd see a lot more panic in the membership and from other advocacy and organizations that are down at the Capitol. But basically, the proposal is to extend private insurance coverage to people up to 100% of the poverty level, with people with serious mental illness and substance use disorders getting a priority in that population. And so what that allows it to do, a lot of BUDS patients right now, they're currently funded through just direct general revenue dollars because they're indigent. You'll be able to draw down more dollars through the waiver to cover those and offset some of the other costs that are now done by general revenue dollars.
So just to follow up with that, so is Medicaid expansion politically dead on arrival?
I believe so. Yeah, I haven't seen anybody on the Republican side saying that they were going to expand Medicaid. The 1115 waiver, the issue before is when Medicaid expansion was our only option. We had President Obama there, and the state didn't work very well with President Obama. The only reason I think we were able to get this 1115 waiver extended was because President Trump was elected, and there's a lot better relationship between the two. And I don't really see any path for Medicaid expansion this session, although there's a lot of bills filed on it. I really see coverage through a new 1115 waiver. The good thing is our former commissioner of the Health and Human Services Commission, Chris Traylor, he is now the head of Medicaid at CMS that will be doing negotiations with Texas. So he's very familiar, and this is really conversations happening at Governor Abbott and the executive level with DC about what type of amend and extend or what's acceptable that we can negotiate for Texas. Anything else? Right there.
Has there been any discussion about competency restorations or anything like that being done on the local level at the correctional facilities?
So the Judicial Council, the bill that came out of that last time, it did a lot with competency restoration. One of the things it did is it provided the framework for an option for jail-based competency restoration. It also pushed outpatient competency restoration. A lot of the Senate Bill 292 projects have gone to alternatives to competency restoration in places other than a state hospital. So that's one discussion that's ongoing. They also prioritize people with Class A misdemeanors and above for the inpatient spots, because the issue is when somebody commits a crime, they're brought before a judge and they're determined incompetent to stand trial. They have to wait in jail for a state hospital bed. They get to the state hospital. They only have a certain number of days for treatment. And once they're stabilized, they're supposed to be brought back to the jail and then go before the judge. The issue is for Class B misdemeanors, the max penalty is 180 days in jail. So because of our wait list, by the time that they get to a state hospital, they're already timed out. So if they get it today 150, they get transferred to Austin State Hospital. They have 30 days of treatment and then they have to be brought back. So a state hospital bed is roughly $600 to $700 a day. You provide 30 days of treatment at $600 to $700 a day. They're still not better and they get sent back to the jail. So we need to prioritize our inpatient resources for people that have that true clinical need. The other piece that people are looking at, I've talked about the judges right now, there's so long of a period in between reviews once a person goes to a state hospital. I think there's going to be legislation going to be filed to take a more frequent review of people, where their symptoms or where they're at, because based on our evidence and the people in our team that work in hospitals like this, you should be able to tell within 30 to 60 days if somebody's going to be able to retain the competency. The ones that talked about the 34% that take up our beds, those are by and large people that have IDD, traumatic brain injury, Alzheimer's. They're people that are never going to regain competency. That doesn't mean that we don't need a place for them to go, but they're essentially being housed for $700 a day in a state hospital right now, and that's not the most efficient use of our resources.
So what's going to be the alternative to those individuals that are not going to be gaining competency?
So Austin State Hospital and San Antonio State Hospital, they put together huge 300-page plans, and that's a part of it. They're looking at the 1915I waiver to design more appropriate settings for them in the community, trying to leverage funds for that. Right now, the 1915I waiver has been used by and large for our state hospitals to transition people out in the community, but we think there's a position to do that for others, but it's going to have to be expanded. There's going to have to be more funding under that 1915I waiver. The other key thing that some communities have done, I believe, is Harris County has done this and Dallas has as well, is we think there was changes made in the early 2000s through our codes that got us where we are with competency restoration on our wait list now. Because the way the codes are designed, if you come in, we've done so much, if you've heard of the Sandra Bland Act or trying to screen for mental illness in the jail when a person first comes into the jail. If a person is flagged because they have mental illness due to the Sandra Bland Act or because what the jail has implemented at the local level, that information has to be given to the judge. And the statute said is the judge has any evidence to believe that a person might be incompetent to stand trial, that person automatically goes into the competency restoration pipeline. And so it might not be, there's plenty of people that are mentally ill that are on our streets right now, and we wouldn't say that they're incompetent to stand trial. We would say that they're in need of acute psychiatric stabilization and treatment. So what Harris County has done to deflect from that statutory process is they do regular reviews of people, even if they end up on the competency restoration wait list, because they're providing treatment in their jails. If they can get them psychiatrically stabilized, they bring them back to the jail and say there's no need for them to be on this wait list or go to a state hospital anymore. They've had 8 days of treatment, they're stable, we need a re-review of this.